Good evening, everybody. Many times, case discussions are based on cases which has obvious clinical findings, and then you discuss the history, clinical findings, correlate them, and then come to a differential diagnosis based on history and examination, then investigate, and then come to final diagnosis. So occasionally we have interesting cases which pose significant diagnostic dilemmas and then management difficulties and options. So we also need to discuss these cases because it will give us a lot of knowledge about how to go about these kind of situations and arrive at a consensus optimum management option, which is the right thing for the patient. So this is one such case, and Vinod will present this. Okay, Vinod, over to you.
Oh. Good evening to everyone. Sir, am I audible, sir?
Yeah.
Yes. A male patient of age 52 years old, who is a software engineer, resident of Bangalore, came to the emergency with a chief complaint of pain abdomen since 4 days.
Is 52 or 42?
52.
Your slide. Move your slide. Make it slideshow and move it one.
Yeah, make it a slideshow, man.
Sir, it is slideshow only, sir.
No. It is.
Reshare it again.
Good evening, Professor Ballal. So nice to have joined.
What about now, sir?
Good evening, sir. I'm enjoying it.
Good evening.
Close and share your screen again.
Okay. Now,
For
ma'am?
the benefit of the
No,
all
sir.
the residents here, we have the pleasure and privilege of the company of Professor Rajesh Ballal, one of the finest teachers and a fine human being. Is Professor of Surgery at KMC, Bangalore. Very distinguished and very humble to go with it. So welcome to Professor Ballal. Thank you, sir.
Very, very kind words. Thanks, sir. I don't deserve it, I think. Thank you very much.
No. That shows you are very humble.
Thank you.
What's happening, man?
Sir, is it full screen, sir, now?
It's not like a slideshow. It is, it is, of course, you can see it nicely. Will it move? Just to see if the next slide comes on.
Yes, sir.
I can't see it moving.
No, sir.
So I think, Sanya, you control the slides.
Yes, sir. I don't have his presentation, sir. He's sharing his screen.
I'll read. Now, sir?
No, it's again just a small slide, but I don't know whether it will move again.
Is it moving, sir, now?
No.
Send me your slides, sir.
Yes.
Abdul?
Yes, sir.
Is Dr. Niranjan there?
Yes, sir.
Yes, sir.
Yes,
Good
sir.
evening,
Yes.
Niranjan. And
Good evening, sir.
Professor Munireddy is joined?
No,
I
sir.
don't think so, sir.
Okay. Rajesh Ballal, sir, we have two consultants, with us, Dr. Niranjan and it's Dr. Subhash. It is Dr. Subhash's case.
Hello,
And
sir.
so I just thought, I'll introduce them to you. Probably you know them, you've seen them.
Probably,
Good
sir.
evening, sir. Yes, sir. Rajesh, sir, I have seen you, sir. I have met you also.
Munireddy, sir, taught me. I was his intern, sir. So
We had actually asked him to come. He'll probably join also.
yeah, probably, sir. Yes, sir.
Vinod, have you sent it?
Yes, ma'am. Yes, sir.
Sorry, Professor Ballal. Usually it's not a problem. I don't know today. It's just his slide is not moving. He's not able
Okay,
to.
it's okay, sir. We'll wait. It's okay, sir.
Hello, sir.
Tanya. Vinod. Vinod, how have you made the presentation, man? Hello?
I think it is on not on PowerPoint, sir. It looks like
PowerPoint, sir.
probably
It is
PowerPoint.
in PowerPoint. Yes, sir.
Then why it is not opening there?
Sir, last time also similarly I presented. I don't know. Now this is not moving.
Sure, it's not on Google this thing.
No, sir. It is PowerPoint.
Slides? Sanya, are you able to do that?
Nikita is opening, sir.
Come on. Okay, start.
Good evening to everyone. A male patient of age 52 years who is a software engineer, resident of Bangalore. Next. Came to the hospital, to the emergency with a chief complaint of pain abdomen since 4 days. Next slide. The patient was apparently all right 3 months ago, then started observing increased gurgling sounds in the abdomen, consulted a gastroenterologist who suspected IBS and treated it symptomatically, and there is no much improvement in the symptom. From the last 1 month, there is a change in the bowel habits. The frequency of emptying bowels has decreased, and consistency is fluctuating from hard to loose stools, but not associated with any blood or mucus, and there is no history of black colored stools. 5 days ago, developed multiple episodes of loose stools, consulted again a gastroenterologist who told it's a part of IBS and given a loperamide. Then the loose stools as controlled. And since 4 days after having loperamide, the patient had developed pain abdomen, which is initially mild, progressively increase in the severity, which is continuous, spasmodic, and diffuse, and there is no aggravating factors, partially relieving on passing stools or flatters. Since 3 days, not past stools, but past one episode in the morning on the day of admission, and not past flatters and and started developing abdominal discomfort since the evening on the day of before the day of admission. Next slide. And there is no history of vomiting or nausea, and no history of fever with chills and rigor, no history of pain in and around the anus. There is no urinary symptoms, no history of weight loss, loss of appetite, jaundice, cough, low backache, and there is no history of any trauma. There is no medical comorbidities, and patient had underwent a surgery for the spine. History is not clear for the and fixation of L3, L4 was done with plates. Personal history, patient is on mixed diet, regular sleep cycle, normal bladder habits. There is no other habits. Family history is not significant. And summary, a 52-year-old male came with chief complaints of pain abdomen since 4 days, continuous. There is no aggravating factors, relieving partially with and passing flatus or stools, and diffuse type, which is spasmodic, with a history of altered bowel habits since 1 month. Can I continue, sir?
Wait. Now, Praveen, do you find anything unusual about this? He's consulted gastroenterologist twice, who's made a diagnosis of irritable bowel syndrome. Do you find anything unusual about this?
It's usually common in the patients of irritable bowel syndrome, sir, these symptoms.
No, man. But do you find anything unusual about how it has been dealt with? Sanya?
No, sir.
Or let us go to Nikita. Nikita, if somebody comes to you with these symptoms, are you comfortable making diagnosis of irritable bowel syndrome?
No, sir. At least there were no minimal investigations or anything was not done, sir. You couldn't conclude into IBS.
Okay, Sanya? Partially correct answer.
Same, sir, with so many on and off having diarrhea and pain abdomen. Colonoscopy should have been considered in this patient before, like, just giving him treatment for his diagnosing as IBS.
Abdul, I want a more scientific correct consultant like answer. Abdul.
Sir, IBS is more a sign of you rule out any mechanical problems first, and then you go with the diagnosis of irritable bowel syndrome.
So I think the word you have to use is IBS is a diagnosis of exclusion.
Yes, sir.
So don't make a diagnosis of IBS willy-nilly without investigating the patient. See, this patient, I think, is very unfortunate that he has gone to the right person who has actually made the wrong choice, because you have no right to make a diagnosis of irritable bowel syndrome without actually investigating the patient. Maybe the first time you can say, okay, give him some symptomatic treatment and see. But if he goes back with persistent symptoms of similar nature, you have it's your duty to investigate. Niranjan, what do you say?
Yes, sir, absolutely, I agree.
Subhash?
At least a colonoscopy and a basic ultrasound should have been done before branding him as IBS.
Correct. Ballal sir, what do you think? How would you have gone about this one, sir?
I would have had a stool examination done to see if there is passing blood.
Yeah.
Because in the absence of blood, the colonoscopy, I think, is a little overkill. I am subject to correction.
The many symptoms that what we call as red flag symptoms, in UK, which is basically, as you said rightly, blood in the stools is probably the first most important red flag symptom. In addition, recent onset of change in bowel habit in form of either recent onset constipation in a person who was otherwise normal, or diarrhea, or alternating constipation with diarrhea, which is what this person had. In addition, abdominal bloating and distension, discomfort, loss of appetite, and if the patient has loss of weight, again that adds credence. And if there is weakness and patient feeling tired, all of these constitute what are called as red flag symptoms. So this patient has had several of them. So I would definitely consider investigating this patient before. Subhash, what is your thoughts?
It was early diagnosis of IBS.
Yeah.
Without
Too early
it-
to make a diagnosis of IBS. They should have investigated. Okay. So the students, the take-home message for you guys is evaluate the patient properly before making diagnosis of IBS, because IBS, as I said, is a diagnosis of exclusion. After you have excluded everything else, you can then label the patient as irritable bowel.
Sir,
Okay. Yeah.
the stool for occult blood, should we have done now
Yes,
at this time?
stool for occult blood should have been done. And as Niranjan said, colonoscopy or ultrasound first. And if the ultrasound suggests, because this is bowel we are investigating possibly, you may even be forgiven if you go one step ahead and get a CT scan of the abdomen. If
I
the
agree, sir. If the pain persists for beyond a week or so and ultrasound is normal, you will be justified in doing a CT.
CT scan, yes, definitely.
I want
Patient
one
had,
thing. Hello. Patient had another finding. He had a gallbladder stone.
Yeah.
So if we had thinking of gallbladder stone and operated 1 month back, we would have missed this transverse colon and this disease also.
Yeah, sure. Right, carry on, man. Examination. Vinod, you still have to, get the art of summarizing in a better fashion than what you've done just now.
Yes, sir.
Okay.
General physical examination. Patient was examined after taking verbal consent in a well-lit room with an adequate privacy. Patient is conscious and oriented during the examination with a KPS score of 90% and ACOG score of 1. Patient is moderately built and well-nourished with a pulse rate of 84 per minute in the right brachial artery. In the BP is 128 in the right hand. Respiratory rate is 18 per minute and temperature is 98.6, and there is no pallor or icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy. On abdominal examination, on inspection, abdomen is distended, umbilicus is inverted and centrally located. All the quadrants of the abdomen are moving equally with respiration, and there is no visible peristalsis, and there is no scars, sinuses, and no engorged veins. And hernial orifices are normal, external genitalia are normal. And palpation, abdomen is soft, diffuse tenderness is present, distension is present, and there is no mass felt, and no organomegaly, there is no guarding or rigidity, hernial orifices normal, and external genitalia are normal. And percussion, tympanic note observed all over the abdomen. On auscultation, hyperperistaltic bowel sounds were heard. On digital rectal examination, sphincter tone is normal, no fissures, fistula or hemorrhoid found, and rectum is roomy, and there is no fecal staining, and there is no mass felt. And proctoscopy, it is normal. And systemic examination
Was normal.
Yes, sir.
So now what is your impression based on your clinical examination? Anybody else wants to differ with this the examination findings? Nikita, do you agree with all of that?
Yes, sir.
Who else has examined this gentleman? Sania?
Yes, sir. I have seen him. I agree with his findings, sir.
You agree with the findings? Okay.
Yes, sir.
So definitely no mass felt.
No, sir. No mass felt. Only the distension of the abdomen was there, sir.
Okay.
With mild diffuse tenderness also.
Sir, after once we kept trials tube and once the patient passed stools of loose stools of around 5 episodes, then abdomen became soft and then able to palpate cecum, sir, actually. It is after around 14-16 hours.
Sorry, I came late.
But it should have been other way around, no? When it is distended, you should be able to feel the cecum, not when the patient passes motion.
No, sir. When it is distended fully, it is completely distended, which I can't palpate, sir.
So what did the cecum feel like? Was it distended?
Yes, sir. It is distended.
Okay.
I want a small clarification here.
Yes, sir.
See, so for somebody like me who's not seen the patient and I don't know what the patient has truthfully, is it our usual practice to include ECOG scoring for every patient?
No, sir. Only in malignancies.
Yeah, that's why I'm asking, because obviously there's something more that I don't.
Yes, sir. I think, you don't usually for all patients.
Correct.
But usually we, use the functional this one.
Fair, correct. So unless, I agree at the end of your diagnosis, you have a diagnosis of a malignancy, then you talk of ECOG.
Yes, sir.
Yes,
Otherwise,
correct.
it's a little.
Vinod, it will make sense when you don't know the diagnosis in the exam to
So I
because you don't
think
know the diagnosis. So
what
it would have been
Dr.
better if you would have
Professor.
spoken about Karnofsky.
Okay, sir.
I
So
agree with
what
Ballal,
Sir
sir.
Ballal is saying to you guys is, unless you are, after examining the patient, unless you have any clinical finding which makes you suspect that the patient has got malignancy, don't say ECOG score. Just stick to Karnofsky. Unless you there are clinical findings which make you feel that it is a malignancy. Okay, so that is the message of Professor Ballal. Correct, sir?
Yes, yes, sir. Yes.
Correct. Okay.
Sorry,
So
Ravishankar, I joined late.
yeah.
Oh, what is the duration of loperamide intake?
Pardon me?
No, I'm asking what is the duration of loperamide intake?
Vinod,
Sir,
how many days?
2 to 3 days, sir. On the 5th.
So this gentleman
Patient has got altered bowel habit since 1 month. History of loperamide 3
3
days.
months.
Sir,
3 months you
loperamide
can't.
for acute symptoms he has taken for this loose stools 5 days ago he had, sir. For that he has taken loperamide.
Before that, he has not taken.
No, sir.
Is it significant in this case?
It might be significant, sir, because sometimes the bowels will be not peristaltic or not functioning because of loperamide of around 3 days, which he has taken acutely.
Okay. So so
You said
Vinod,
it's clinically, how do you differentiate between cecal distension and cecal thickening? You said clinically it is cecum is distended.
Sir, it is the mass is not like a hard mass, sir. So it might be gaseous distension only, I felt.
And when you have got a strong abdominal muscles, how can you feel a gaseous this thing organ?
Sir, it is fully distended, sir.
How can you say clinically fully distended?
see Vinod,
The
what
distension is a CT finding or ultrasound finding or
Vinod,
X-ray finding. You said you should say whether it is palpable or not. That's all.
Yes, okay, sir.
Vinod,
Yes, sir.
it is hardly ever possible for anybody to, unless there is a as Srikant says, unless there is a hard mass or a very thickened bowel on the right colon,
And then you can say mass. Otherwise,
it is impossible to
palpable.
say. It is impossible to say that the cecum is distended. It is
Okay, sir.
only on the X-ray, if you have done serial X-rays, or on the CT, that you will be able to say that the cecum is distended. So why it is important is, especially in patients with patients who have inflammatory bowel disease, who come with the distended abdomen, you have to do serial X-rays of the abdomen to look at the cecal distension. If it is increasing, then it becomes an indication for surgery. So that when it is going to toxic megacolon kind of picture. Not so common in India at the moment, but it probably will become more common. So that is the one. But you cannot make out whether there will be tympanic note and distension may be tender, but you can't feel the cecum as such unless there is a hard mass or a sort of pulling up of the ileocecal area. Then you may feel it as a mass. Ballal sir?
Agreed, sir. Agreed, sir. Nothing else to this one.
Okay.
We'll see what there is, sir. We'll go on.
Okay, carry on. So what do you think is going on, man?
Vinod, do you want to add something in auscultation?
Vinod, do you want to add anything in auscultation?
Peristaltic bowel sounds. No, sir, I don't.
Sir? Okay, so with these findings, what are you thinking of, Vinod?
Sir, probably I'm at age of 57 years. It should be an intestinal obstruction, but the cause might be different, sir. something secondary to mass or a paralytic loperamide induced things, sir. So mostly I go with the mass only, sir.
Don't go with loperamide induced things. It is very uncommon. So don't even think about that.
Hey, you have written paralytic ileus.
And usually,
Auscultatory
loperamide-induced paralytic ileus, there will not be any diffuse tenderness.
And
You have mentioned diffuse
hyperperistaltic
tenderness.
and
Yes, and it
hyperperistaltic.
will not be hyperperistaltic.
Paralytic ileus, how will you get hyperperistaltic sound, man?
Sir, these are all provisional diagnosis, sir. I have
No.
ruled out because of
Hello,
hyperperistaltic.
slowly. How can you diagnose paralytic ileus when there is hyperperistaltic sounds?
And tenderness. See, paralytic ileus, there will be no tenderness.
Yes, sir. I kept as a provisional, sir. I have ruled out
No,
because of
Vinod.
sir.
Vinod, you
even
can't
go
keep it
there.
as a provisional also.
Okay.
Provisional diagnosis is what are all the possibilities. If you are
Possibilities.
saying tenderness and if you are saying there is what is it, hyperperistaltic bowel source, then it cannot be paralytic ileus.
Yes, sir.
So it is not a probability also.
Vinod,
Yes, sir.
sorry to say this, but if you keep persisting like this, I'm sure Professor Ballal will fail you. Because
I was about to say this.
it doesn't make sense.
Okay, sir. Sorry,
Your thinking should be based on the findings and logical analysis of
You
the
are
symptoms and
presenting the
signs.
case to learn.
Yes, sir. Yes.
You should
And,
never have thought about paralytic ileus. Professor Ballal, sir.
yes. No, like somebody correctly said, provisional diagnosis must be possible. You're not giving a diagnosis for the sake of giving a diagnosis.
Yes.
That was very nicely brought out by somebody just now.
Yes, sir.
Yeah, okay.
What is the spelling of induced?
Sir.
Induced is,
What is the spelling of induced?
intussusception is also wrong.
Intussusception also is completely wrong.
Completely wrong.
How can anyone make a intussusception diagnosis clinically when they have distended abdomen?
In a 52-year-old man.
Vinod, these are all theory what you're put it up there. Okay. So you'll be failed in the exam if you put these diagnoses there.
Okay, sir.
See, altered bowel habit, superimposed obstruction, first diagnosis malignancy should come.
See, I think so there is probably, Rajesh Ballal sir, myself, Subhash, Srikanth and Niranjan included, there must be about 100 to 150 years of clinical experience. We have never seen a loperamide induced ileus so far. It is some, I don't know whose figment of imagination it is, but take that out of your mind.
Okay, sir.
Okay.
Sir, loperamide induced ileus is a reality, but it will not present like this.
Correct.
They will have only distension and
They will
this
have
one
constipation.
probably. Constipation, not pass motions for 2-3 days and all that. But they
And
will not
enlarged-
have diffuse tenderness. They will not have hyperperistaltic bowel sounds. If you are calling it as ileus, it will be silent abdomen.
Correct.
Here we will have loaded fecal matter there.
Right. Okay. So intestinal obstruction accepted, possibly due to a mass accepted, and additions maybe intussusception. There isn't any clinical factors to suggest it's intussusception because you should have had, I think there usually is, blood in the motions with that. So, and, adults presenting with intussusception, if for example, there is either a polyp or a tumor acting as the in the apex of the intussusception is possible, but they will have other symptoms. Like, I think mainly blood in the motion, which is one of the clinchers for intussusception. So I wouldn't consider even intussusception at this stage. Okay. How will you investigate this gentleman? Now that he's come to you with this finding.
Yes, sir. Sir, my first investigation will be erect X-ray abdomen, sir, to confirm whether it is intestinal obstruction or not.
Okay, so have you got the erect abdomen?
Yes, sir.
Vinod, sir, 1 minute. Before going into, why can't it be gallstone pancreatitis? Can it be gallstone pancreatitis? Because patient has gallstones history, and you say diffuse tenderness. Can it be gallstone pancreatitis?
Sir, but vomiting, sir, something epigastric.
Yeah, gallstone pancreatitis can present with vomiting.
He doesn't have vomiting or upper abdominal pain.
Yes, sir.
So See, you have to answer.
I'm asking you, man. I'm asking you whether you can diagnose it as gallstone pancreatitis.
Sir,
You say
less
yes or
chances, sir,
no. If
because of
yes,
vomiting.
why?
There is
If
no vomiting.
the vomiting is not the presenting sign of gallstone pancreatitis.
Yes, sir, and
They
there is
will
also
have
history
diffuse
of 3
pain,
months,
severe
sir.
pain. You have to justify. That is what I'm asking.
Yes, sir.
Now pain abdomen is worse since 3-4 days.
Yes, sir.
It could have been a biliary. Could it have been a biliary colic recurrent? Now patient has presented with gallstone pancreatitis since 3-4 days.
So
Diffuse
what about
tenderness.
his altered bowel habits then, sir? The loose stools.
No, I'm asking Vinod.
Yes, sir,
Sanya,
there is.
I'm
Oh,
asking
yes,
him.
sir.
Let him think. Yeah,
Yes, sir.
I know it can't be. I'm asking him. He has to justify. I just wanted him to think.
Sorry, sir.
Yes, sir. And
See,
sir,
where
Okay,
is the
carry
pain
on.
of pancreatitis, man?
sir,
Where is the pain of pancreatitis? What are the characteristic features of pancreatic pain?
sir, it will be in the epigastric and left, and it is referring to the back.
Correct. Severe illimitable agony. That is what Professor Moynihan said. So severe
More than
upper
vomiting,
abdominal
it will
pain.
be like that. What sir has mentioned. The pain will be classical. More than vomiting. Just because there is vomiting, you can't diagnose gallstone pancreatitis. It can be there in obstruction also.
Yes.
Okay, carry on.
So a plain X-ray abdomen. Put it up. There are a lot of things to discuss. Okay, read this quickly.
So it is an erect X-ray abdomen, sir, with multiple air fluid levels.
Okay. What
Looking at
else do you see?
Looking at the X-ray, do you think it's small bowel or large bowel, doctor?
It is small bowel, sir.
How do you diagnose?
Sir, it is in the central area,
Hmm.
and the
Anything?
diameter is
What is in the central area?
the air fluid level, sir.
What is there within
I
the
am
air fluid
seeing in the
level?
sides, Alba.
What is there within the air fluid level in the center?
What is the classical thing that you see?
Circular rings, sir.
What are they called?
Plica circularis.
No, valvulae conniventis. So beautifully seen valvulae conniventis here.
Yes.
And doctor, if you see near the right hypochondrium,
Yeah, I was about to say.
yes, I'm not very sure that small bowel.
That is large bowel. That looks
Large bowel,
like
sir.
hepatic
Large
flexure.
bowel.
That looks like hepatic flexure.
Yeah.
Okay, once patient gives history
And
of
what is
altered bowel
characteristic?
habits,
Sir,
once patient gives history of altered bowel habits, first thing we should think is large bowel, nothing
yes.
else.
Okay, carry on.
Yes.
What observe is large bowel or small bowel? At least now you tell.
Sir, both are there, sir.
See, the thing is, if there is only small bowel that is seen, then you say it is small bowel obstruction. When you see distended large bowel and also distended small bowel, it obviously becomes a large bowel obstruction, no?
Yes.
Is it
Yes. Yes,
very
sir.
logical, man?
In what condition you get both small and large bowel obstruction?
Sir,
In
when
final year or first year?
second year.
Okay.
So that was wrong question. He's either final or first year. Isn't it?
First year means you should have shown some this thing, lenience.
Okay.
Yes.
So carry on, man.
Yes. This is on the at the night of admission, sir.
Okay.
Next.
Right. Move on.
Yes, sir. Next. Praveen, next.
Somebody.
Got a CT.
One more X-ray.
X-ray.
It's not.
This is in the morning, sir, which was done.
Findings are the same or anything different?
Findings are same, sir, with decreased amount of air.
Why X-ray was repeated?
Sir, because he passed stools in the night, sir, actually 5 episodes. So we thought.
Why should you do X-ray when he passes his tools?
in obstruction might have relieved. So
So what?
to confirm, sir. Otherwise, we can proceed for the CT.
See, the thing is, you go by patient's clinical findings, man. X-ray, unless you are suspecting something very specific, there is no need to repeat the X-ray.
Yes.
Okay, carry on. Next investigation. We are wasting time here because there
If
are
he
lots
has
of other
passed
things.
the motion, then it is not an emergency. Then you can go to find out the cause of obstruction.
Okay. So CT, yeah.
This is a CT plane, sir, which showing a mass in the mass, sir, which is irregular in shape.
Where?
In the transverse colon, this one. This is the mass.
Much more clearer now. Yeah.
Yes, sir. And ascending colon and cecum are fully dilated, sir.
Okay.
And when contrast given rectal edema, so there is a delayed contrast passing proximally, sir, from the mass.
Where is the contrast?
This is the contrast.
What contrast was given?
Barium, sir.
No. Usually rectally they don't give barium, man. What do they give? Barium is given up. Usually nobody gives barium. What is the contrast that they use rectally?
If you don't know, please say don't know. Don't guess.
Anybody? Sania? Abdul?
Gastrography, no? Or hydrogenated.
I think usually they give air rectally to delineate the colon. I don't think they use gastrograph. Gastrographin is given as oral contrast usually.
It is there in the next slide. Praveen, just turn the other side. CT report.
Sorry, can you just go back to the previous CT? I'm sorry. What is that on the right? Can you read this right top image for me? What's that by the side of the liver?
This one, sir.
Yeah, that's why I don't have a pointer either. That image, yes. What is that sort of gas shadow by the side of the liver?
This one, sir.
This one, man.
Just below the liver.
What you showed just now. What
Yes.
you just now showed.
Above the ascending colon.
Yes.
Was there free air or is it fluid?
No, sir. There is no free air, sir.
Or is it the colon which is gone there?
Colon.
It is a hepatic flexure. Dilated hepatic flexure. Okay.
Go on.
So, what does the report say?
Circumferential neoplasm in the distal transverse colon causing obstruction, sir, which is 5 centimeters in size. Go back, man.
What is 5 centimeters?
Have they mentioned what contrast they have given rectally?
They just mentioned positive rectal contrast.
IV contrast here they have written Omnipack. Then it is not rectal this thing.
What is Omnipack? Omnipack is given orally.
That is what. IV they have given.
They have given IV. I think rectally, as far as I know, rectal contrast is usually.
Omnipack is 350 volume, sir. 350 volume to 120 ml. That is Omnipack is gastrographin.
Correct.
It contains that sodium ditroside.
So I think the rectal contrast is usually air, because it gives you the contrast between the oral contrast, which is usually that's what gastrographin or omnipath, and the air in the large bowel.
Sir, I have one question for Vinod, sir.
Yeah.
What is the size of the cecum which shows that there is an impending perforation? So that size on CT, if you find that size, that means you have to immediately operate. The
9
close look
centimeters.
assessment. Huh?
9 centimeters, sir.
No, more than 11 centimeter. So if the cecum on CT is more than 11 centimeter, it's an emergency, impending perforation
Okay.
with a
Right.
patent ileocecal valve. Yeah.
So what else will you do now, man? You have done the CT. You think it is a possible neoplasm in the nearer the splenic flexure with dilated cecum.
Yes, sir.
How will you next? What other investigations do you want? Anything else?
No, any notes?
Vinod, is it a closed loop obstruction or open loop?
Sir, it's open loop, sir, because small bowels were also dilated.
Okay, what is closed loop?
When only the large bowel up to cecum was dilating without a IC valve open.
Which one is more riskier for cecal perforation?
Close it, sir.
Yes. Okay.
Okay. So any other investigation is required in this case with these findings?
No nodes enlarged, is it?
Enlarged, few enlarged pericolic lymph nodes were shown. Maximum size is 13 into 10 mm.
Is it significant? Pericolic, is it?
Yes, sir.
Size?
13 mm, sir, large. 13 into 10 mm.
Is it significant?
Greater than 1 centimeter, significant.
May or may not be when the presence of the obstruction and in these situations. It may be significant, but it may be just inflammation because of the obstruction also.
Would you be worried about the free fluid on CT?
Vinod, will you be worried?
Yes, sir. Some.
What does it signify if there is free fluid?
Free fluid in peritoneal cavity, yeah?
Yes. On the CT, it says my small amount of free fluid. So I wanted to know what he's thinking.
So, inflammatory pathologies and ascites.
There is
already they have given malignancy as diagnosis. Now we are talking as inflammatory pathology.
Regarding free fluid.
Again, it may be one of the signs which may indicate that there is impending perforation. The colon is so dilated, there
can be reactionary free fluid from that because of obstruction. Or second is malignant ascites. And
okay,
Vinod,
so
what that in that findings first line, what is it called as if it is there in some other condition where rest of the things are normal? In findings first lines.
on the previous slide.
No, previous findings.
In the findings, the first sentence, sir wants to know.
Interposition of colon.
Floppy cecal.
Somebody answered. Nikita, I think, answered. Celerity syndrome.
Yes.
Okay.
See, they have done a colonoscopy. Was it required to do a colonoscopy in this patient?
Sir, as it in obstruction, emergency, we can directly go, sir.
But in what situation will you consider doing a colonoscopy?
If patient is stable and we need a diagnosis, then we can go for a
no, you have a diagnosis. No, you have a diagnosis. There is a, CT is almost, the findings are very classical of it's an apple core kind of lesion. So it is almost certain it's a malignancy, but you may still consider doing a colonoscopy in certain situation. What is it?
No, other synchronous. lesions.
No. Those things are not that important in an emergency, man.
Yes.
How will you
And
manage this?
also when you're considering probably stenting, if patient is unfit and you want
that
and it is
that
metastatic, if you want
is
to
the
consider
answer
chemotherapy.
I wanted. See, if the comorbidities patient is obstructed, you may want to optimize the patient. So if you have the facility, you do a colonoscopy and stent the lesion.
Yes, sir.
So that will relieve the obstruction. It will buy you time to manage this patient in a more organized and more controlled manner. Balal sir?
Yeah, one basic question. What is that stent called, doc? What sort of stents are they? The
What
colonic
is
Hello.
Yeah, your voice
this is
sometimes
not
breaking.
audible, sir.
Yeah. What is that stent called? That the colonic stents they're talking about?
No idea, sir.
Heard of something called SEMS?
Self-expanding metallic
Self-expanding, yes, sir.
covered.
See, these stents are made of material called nitinol. They are self-expanding and metallic. So nitinol is a metal, and so they basically it will expand to sit snugly across to up to the
Guru,
circumference.
you are making it as a theory. Let them answer. Give them, let them
No,
present.
if they
Let
don't
them
know,
read and come.
self-expanding metal stent.
That's all. Let them
SEMS.
go and read about SEMS.
So that
All
was
the, all
one
the
of the
pages
thing
go and
that you
read
could have
about
considered.
SEMS. All of you read about SEMS and put it in the WhatsApp.
Okay.
So
No
one question.
response.
Right, sir.
Yes, sir. Yes.
Okay. Now, how will you manage this patient? You have the CT, you have the patients, in front of you. How will you manage this patient? What are the options?
Sir, extended right hemicolectomy, sir.
No, please tell about colonoscopy findings.
Colonoscopy findings, man.
Yes, sir. Ulceroproliferative growth complete 5 centimeters on the splenic flexure, sir. In the transverse
5
colon.
centimeters in 5 centimeters proximal or distal to splenic
Proximal to
flexure. You have
the
to talk.
proximal to the splenic flexure, sir.
Okay.
Could they negotiate beyond this thing, tumor?
No, sir.
Or they mentioned it?
Yes, sir.
And there was another polyp in the sigmoid colon, right?
Yes, sir.
That they removed.
Yes, sir.
Okay.
But
So,
will you do colonoscopy when there is total obstruction and cecum is dilated, there are air fluid levels?
so that's what colonoscopy, if you are asked in the exam, is not necessary unless you are, as I said, you are considering, as Niranjan said, patient who is not medically fit or the patient is quite unwell or unstable, then you will want to stabilize him, then you can consider doing a colonic stent. Otherwise, colonoscopy is not indicated as far as the medical so management is concerned, especially if they ask you in the exams. Okay, so now this patient is there. He's a 57-year-old with no comorbidities, fit and well. You have hydrated him. How will you proceed?
Sir, I'll go with exploratory laparotomy and.
Guru, this is a malignancy. You don't work metastatic work, Papa.
Sir, already CT and chest CT abdomen and CT chest was done, sir.
Where is you didn't tell about CT chest or anything?
CT chest was normal, sir. Actually.
Vinod, your answer, you should not answer like that. What is this? This is a case of emergency obstruction where tumor is obstructed, cecum is around 11 centimeters.
So you will be forgiven to say that the priority is to deal with the patient now.
No,
Then
no.
we
When you
can.
have done a colonoscopy, then you have got time to do other investigation
Correct,
also.
correct.
Otherwise, straight away you should have taken for laparotomy as stabilize the patient and then take without any investigation colonoscopy.
Correct. Okay, so you have stabilized the patient.
Yes,
Hello.
sir.
How
Where
will
do
you
the
manage
where
this
do the
patient?
carcinoma of the colon metastasize?
Most commonly to liver, sir.
So this liver was normal, right?
Yes, sir.
Okay. And
So
see,
in case of emergency, there is no question of working for metastatic, doing a
Yeah.
metastatic workup. You can do the metastatic workup later.
later,
So priority is to relieve the obstruction
Yes,
correct.
sir.
and get out safely.
Not even colonoscopy. You will worsen the case.
No, colonoscopy is not indicated, as I said, unless you are
Yeah.
doing the stent. That's all. That's the only indication. Okay. Now, how
Sir,
will you manage this? What are the possibilities you think of when you open the abdomen? What are the things you assess? You are the surgeon, you open the abdomen.
Yes, sir.
Is there any role for laparoscopy in this patient?
To just for the mobilization and to know the other visceral organs can be seen and to know the any medicine.
When the entire small bowel is dilated, how can you do a laparoscopy?
Yes.
Laparoscopy in a patient coming with intestinal obstruction is difficult. That is the answer you should give.
Yes.
And ideally should be avoided if it should be done only if there is expertise available and in skilled hands. Like usually it should be avoided in emergency. That too in a colonic obstruction with malignancy.
Because there is no space to do anything. Even for mobilization, it's very difficult because visibility and absence of space. Sir,
I
Rajesh
think
Ballard, sir, what is your take, sir?
Yes, I'm with this, sir. Only thing is, I would not have this one done a colonoscopy sort of.
Correct. Colonoscopy is very
Yes.
categorically not
Yes.
required.
Yeah. But otherwise, yes, sir.
Okay, right. So, Vinod,
Sir.
you've opened the abdomen. What are the options you are thinking of in this patient?
Sir, extended
What is
hemicolectomy.
the safe? What is the safest and what is the safest and ideal thing to do in this scenario?
Extended right hemicolectomy.
right or
Ileostomy.
left, right or
So
left.
and what
And what?
extended right hemicolectomy and then
Ileostomy.
Extended right or extended left?
Sir, because of fully cecal dilatation.
Oh,
so no. See, what you have to say is when you open the abdomen, I will look at the viability of the cecum.
Yes,
Is
sir.
the cecum does it appear dusky and bluish? Is it very dilated and thinned out and unlikely to survive? So these are the factors you have to explain. When
Yes,
you
sir.
do a laparotomy, you have to say, is the cecum so dilated? Is it viable or not viable? So that is one thing that will help you to make the decision whether you should, as Srikanth said, do a left hemicolectomy or an extended right hemicolectomy or something more, which actually what Dr. Subhash did.
Yes, sir.
And
if it is a closed loop, you can manage it differently because ileum and small bowel loops won't be dilated. If it is open loop where small bowel loops are also grossly dilated, then what you will do?
If it is an open loop, ileostomy and
see,
Ileostomy is if it is grossly dilated and if there is gross discrepancy between the lumen, it is better to do ileostomy.
yes, sir.
If it is closed loop, probably may think of anastomosis if patient is stable enough and tolerate the anastomosis.
and what other thought processes go through your mind to consider something more radical than actually what Dr. Subhash did? Did you question him, why are you doing this procedure?
Yes,
Anyone?
sir. Sir said the lymph nodes are also few lymph nodes were palpable towards the descending colon side also, sir. So, sir,
No.
did subtotal colectomy.
No. I don't think he would have done it because of that. See, what is the the important thing is, one is the viability of cecum. Second is the age of the patient. See, is a 52-year-old patient who is young and he already has a polyp in the sigmoid which has been resected. So, and he has a tumor. So he will fall into this category of what we call as HNPCC, where he has multiple, hereditary non-polyposis colon cancer. So in those situations, patients are more prone to developing more polyps and more cancers. And he's young and he already has a polyp in the thing and the cecum is probably not viable. And doing any other procedure, for example, a left hemicolectomy, and then putting the risk of a dilated distended colon and anastomosing that to the descending or the sigmoid is not a palatable option. So the ideal thing would have been to do a subtotal colectomy for the reasons I've already explained, and then do a ileorectal anastomosis because the ileum will be dilated because this is a non-closed loop obstruction, and the diameters will probably match, and you have taken care of all the possible disease segments and possible future malignancies, and it is easier to keep an eye on this because you just need to do a sigmoidoscopy up to 30-35 centimeters. So future surveillance is also very easy. So for these reasons, subtotal colectomy is the right option. Did you understand?
Yes, sir.
Anybody has a contrary view to this? Niranjan?
Sir, okay.
No, sir. No, I agree.
Sir, it also depends on one question, sir. It also
Sir,
depends on
two more. Yeah, Abdul. Continue.
it also depends on what type of polyp it is, because polyps are divided usually into that non-neoplastic and neoplastic, and usually polyps with a malignant potential are the adenomas.
No. See, the
Correct.
Abdul,
Yes, sir.
if you have a malignant polyp, already malignant lesion, and there is another polyp, I think you will be very stupid to think that the other polyp is not adenomatous. It will be adenomatous.
So they are in FAP.
Very rarely, man. No. Don't go there.
Syndrome, they are more hematomatous
If
polyps.
you have isolated polyps, it may be a hematomatous. If you have a malignancy and another polyp, you have to think it is, another adenomatous polyp only.
Okay,
what was the colonoscopic, that polyp nature on colonoscopy?
Long pedunculated.
No, biopsy.
Biopsy report yet to come.
No. Long I wanted the nature. You said adenoma and this one. No, long pedunculated. What was the size of the polyp?
1 into 1 centimeter.
Small one. Okay.
Sir,
Fine. So,
what they say is, if it is hematomatous, you can leave aside that sigmoid. You don't need to. If it is adenoma or tubulovillous adenoma, then it has a very high malignant potentially, and get rid of that sigmoid as well.
Tumor
So
biopsy was done, huh?
If the biopsy is not
tumor
yet done.
biopsy was done.
What is the report?
That has to come, sir, tomorrow.
See, when you are not waiting for the report, why did you take the biopsy?
Correct.
What about tumor marker, CA?
Huh?
CA was normal, sir.
When you are not patient enough to wait for the tumor report, biopsy report, why did you take a biopsy? Why did you do a colonoscopy? Huh? Quackery it is.
Rajesh, sir?
Enjoying the discussion, sir. I'm very
No, if you were faced with a situation like this,
yes,
what would you do? You
Yes,
have
sir.
a very dilated cecum,
Yeah.
a lesion in just at the splenic flexure, and he's a 52-year-old young man, and there is another polyp in the sigmoid.
Yeah, probably like you said, it's safer to do a subtotal colectomy and
Correct.
take out that polyp. But I think our problem has started because we are, on the CT also they diagnosed, but the colonoscopy was the culprit, I think, sir.
Correct.
No, when you have done a colonoscopy and done a biopsy, you should wait for the biopsy report, no?
Srikanth?
Yes.
we don't have to wait for the biopsy report, but I agree
No,
with
no, no.
you.
Once you have done a biopsy, you have to wait for the biopsy
No, no,
report.
no,
Then why
no,
did
no,
you
no.
take
It's
the-
like this. I agree with you. See, colonoscopy was probably redundant and not necessary, but the patient's condition is in obstruction where the cecum is about to go. You can't wait for the biopsy report. So it is an emergency. You have to do it. So I agree with you. The colonoscopy was not necessary.
How many days after admission surgery was done?
Sir,
How many days
Subhash,
after
ಎರಡು
admission?
ದಿವಸನಾ?
How many days after admission surgery was done?
sir, around 36 hours, sir.
36. Yeah. Okay.
Sir, I have a doubt. Sir, in this patient, anyways, colonoscopy is done, and it is a pedunculated polyp of around 1 centimeter.
Yeah.
Anyways, the management would be polypectomy only, no, sir, which is
Pardon
already
me?
done.
What was the?
Anyways, the management for a pedunculated polyp of around 1 centimeter, the management would be polypectomy, which is anyways done in this patient already, sir.
No, I think you missed the point. I think you missed the point. There was very clearly, it was mentioned that you must consider HNPCC here. So you're not taking out the rest of the colon for that polyp. You're taking the rest of the colon out for the future. Sir very clearly said this is a relatively young patient who's more at risk for synchronous malignancy or sorry, a metachronous malignancy.
Okay, sir. Okay.
I think you missed that point.
Yes, sir. Yes, sir. Thanks.
What would be the surgery if colonoscopy was not done and not if colonoscopy had not picked up a polyp?
Yeah, yeah. Subhash, you are a good question. But your CT had already
CT was already
indicated
showing,
that
sir.
CT has also indicated there is a polyp in the sigmoid.
Okay.
So your treatment will not change.
Hmm.
I would think.
Okay, correct. Now, what would be the surgery if polyp was not picked up in this case?
Yeah.
There was no polyp antado.
Then I think
there is no polyp. Okay.
Then the thing then would be for you to, again, obviously the cecum is almost gone, so you are almost, definite to removing
No,
the
almost gone and on laparotomy. What was the sequel pending?
Subhash, what was the cecum looking when you opened?
It was distended. It was distended. Even the terminal ileum, small bowel was distended.
Alala, there was no suspicion of gangrene. No?
Yeah, no perforation, no gangrene.
That's what. Then it is healthy.
Yes, it is over distended.
Or distended. So there is other thing that you can do. Anybody else? Is Sania or Abdul? There is another important thing that you can do to save the colon. If you want to save the colon, what will you do?
Stent it first and then wait for
Yeah,
it to
that
settle. and
stenting
then-
we had already spoken about.
Yes, sir.
Now on the table.
Sir,
you have
we
all the
can do a
facilities.
colostomy, transverse
What?
colostomy. Colostomy, sir.
No,
Transverse
no, no,
colostomy.
no. Not
Abdul,
colostomy.
how can you do transverse colostomy when there is a tumor in the transverse colon?
No,
If
sir.
you are not considering resection, then you do a diversion proximal. If patient is not fit enough and you want to give chemotherapy, then that is fine. Proximal transverse colostomy. But otherwise, how will you do transverse colostomy?
Sir, even if we are considering chemotherapy and that management, sir, would we do a colostomy or ileostomy would be
No,
better
no.
for this patient?
No, I think Abdul, you are going on the wrong track and leading Sania also on the wrong track. See what my question was very clear. On the table, there is another very good option, which is oncologically sound, which is a procedure called on-table lavage. So
Yes, sir.
what you do is you do an appendicectomy, put a large bore Foley's catheter through the appendicular orifice, and then you to the just proximal to the tumor, you take this anesthetic, these scavenger tubes, which is sterile, and connect it to that, and then use about 7 to 8 liters to clear the colon. So the effluent that you get should be clean. It should be like water. Once you have done that, then what you do is you can then salvage this colon. That is, if you want to salvage it, then you do a oncological procedure, which actually is what Subhash said or what Srikant said. You can consider doing a left hemicolectomy and then joining the transverse colon to the either the descending or the sigmoid colon. And anyway, you have got a cecostomy, which is the so you keep the cecostomy as a defunctioning thing. And once the patient passes motion and you are happy with it, you can, and cecostomy will be anchored to the abdominal wall. So after 5 to 7 days, you can take out the cecostomy tube. So that is another procedure that you can do. So
Yes,
these
sir.
are the various
That
options.
that is the ideal procedure, actually.
Yeah, yeah.
Sir,
So
actually, when we were discussing this, sir, what me and Munir sir, we were discussing. So what sir said is, in an obstructive lesion like this,
yeah,
a colocolic anastomosis will give away faster.
correct. No, that is
So
why. But
better to have a ileocolic
No.
anastomosis.
Why? Because colocolic, it is on the left sided. The tumor is closer to the left sided, where vascularity is compromised.
questionable.
Yes, sir.
Yeah,
So, questionable.
So in this case, if you just resect only do left hemicolectomy, so there are
yeah.
more chances of colocolic anastomosis giving away. So sir was like, better to do an ileocolic anastomosis.
Correct.
Always.
See,
That
that
is
is what.
correct.
See,
That is
basically, what has been done is ideal. But what I'm just discussing
Resection
all the options
anastomosis
that are
with
available.
prophylactic ileostomy, or that's all.
See
How
the
many? I have seen only one cecostomy till now. How many have seen cecostomies or done?
I'm not sure. That's why, sir,
cecostomy is not
cecostomy
very common.
probably is very difficult to manage also.
It's not very common.
Yeah.
No, I'm
And
just
one
Cecostomy
more,
can be done.
yes, sir. One more thing, sir said was the transverse colon to mobilize and get anastomose to the descending colon will be little challenging in this scenario.
no. It will come down. See, if you take the hepatic flexure and all to disconnect the momentum, and you create that plane, it will come down. It's not a problem. But I think the premise is right. The vascularity of the left colon is suspect, but the vascularity of transverse colon is not suspect. But if it is very dilated, then potentially there is chance of leak. So ideally, what Munireddy sir says is correct. Better to avoid colocolic anastomosis generally, especially in obstructed patients. Definitely, you should avoid it. Ballal sir.
Yes, sir. Yes, sir. Then I don't think we had any other options in this because the cecum was so dilated. I think it's safer to take it out, sir.
Correct.
And we've also agreed that the sigmoid polyp was worrying.
Correct.
Don't think we were left with any other choices.
See, Sania, to answer your question, see, I think Swaroop will also back me up, but Swaroop can highlight. See, HNPCC polyps, they appear much more faster than usual polyps. See, for example, it is said that it takes anywhere between 7 to 13 years for a polyp to reach a size of 1 centimeter. But in HNPCC, that time is much less. So more malignancies can, I think in a region of about 20%, you have metachronous tumors. So
Now,
that is
whatever
why.
surgery you have done, he needs surveillance with colonoscopy regular.
Correct. ಅದ್ರ ಬದಲು ಈಗ just sigmoid scopy ಮಾಡ್ಬಿಟ್ರೆ ಆಯ್ತಷ್ಟೇ. Swaroop, what is your view?
Yes, sir. I agree with the difference in biology between HNPCC and FAP. FAP, it's easier to do colonoscopy and look at polyps and remove the mass when required. But HNPCC, they tend to have very almost invisible kind of malignancies. So it's better to go for
Sir, but my only question here is, will in HNPCC will it be a pedunculated polyp?
Yeah. It can be either
But
pedunculated or sessile.
most likely they are like more like sessile rather than pedunculated, no?
I agree with you, but I don't think it is very strictly always
Yeah, it is all. It
sessile.
is.
Swaroop?
It's not likely to be pedunculated in HNPCC. Less likely to be pedunculated.
Okay.
In FAP, it is more likely to be pedunculated.
Okay.
And numerous also. In HNPCC, we may not see the typical polyps which we are expecting in FAP. More of diffuse, broad-based lesions.
Okay. So how is the patient doing so far?
Sorry, I didn't get what was done ultimately, sir.
We did a I think Subhash, please. Subhash?
Subtotal colectomy and laparoscopic cholecystectomy.
Okay.
We did diagnostic laparoscopy and mobilized this clinic structure first.
That's
And did laparoscopic cholecystectomy and made a minimum midline incision and did a subtotal colectomy.
Yes. Did you do a diversion, sir?
And ileocolic or ileorectal anastomosis?
Ileocolic.
Ileosigmoid colic.
ಅಂದ್ರೆ ಸಬ್ಟೋಟಲ್ ಆಯ್ತು.
Subtotal.
Surprisingly, what we have seen and even literature backs it up. Rajesh Ballal sir.
Yes, sir.
Patients who have subtotal colectomy with ileosigmoid or ileorectal anastomosis, qualitatively in terms of quality of life, have much better quality of life than people who have right hemicolectomy, because the diarrhea seems to be much more common with right hemicolectomy due to the Alva sir.
Point taken, I think.
Yeah. So I
Sir,
think
one more consideration which we didn't think about is if there was poor nutritional status, because patient was having this for 3 months.
Correct,
that also has to be considered before taking the decision for anastomosis.
Correct.
Lap cholecystectomy in this setup, sir? Comments?
Because again, resurgery would be difficult and we finished up the lap chole also for it.
Well, agreed, sir. Now with the dilated bowel, was it easy or?
We could do some, we could manage it.
First lap chole and then later laparotomy, na?
No, sir. Yeah. First laparoscopic sigmoid split section mobilization.
Oh, you could get the access, sir.
Yes, sir.
With dilated bowel.
Yes, sir.
Decompression ಆಗಿತ್ತು.
Oh.
Because the small bowel was also dilated, and then they put the Ryle's tube and it had decompressed nicely.
Yeah. Good.
Sir, one question, sir. If this sigmoid polyp turned out to be malignant adenoma, so what would be the next step? You have to do panproctocolectomy?
No, you don't have to, because whether you wanted to do it or not, you have already done a sigmoidoscopy or attempted colonoscopy. You've gone up to the tumor. You know, apart from this polyp, there is no other polyp. So you just do a surveillance, because you don't.
Sir, here one question. Because it is already. Sir, one question here. The sigmoidoscopic, colonoscopic, that sigma biopsy was already done. Sigmoid polypectomy was already done. How did the intraoperatively, how was the site of that resection identified? Like whether that margin, because they've said sir said there is anastomose to sigmoid colon, whether that part of the colon has come out or not, how will it be sure? How will they be sure? If it comes as positive, then again whether we have to go back. If margins come positive,
He has resected the entire sigmoid also.
No.
Part of sigmoid is still there.
Subhash, but you are able to see the polyp site?
No. On table, no, sir. I couldn't appreciate anything. It was looking like a normal bowel, normal sigmoid.
So Niranjan, to answer your question, if you are thinking of these things, you will have to
tattooing.
Tattoo ಮಾಡಬೇಕು. You have to tattoo with India ink, then you will identify that area.
Yeah, that is what I was asking.
If you are doing laparoscopic resections, you will not see anything from outside, especially if it is for polyps. There you have to tattoo them. Correct.
That is why, because if you have done sigmoid colectomy for reason of it being cancer and part of HNPCC, then if this margin comes positive, suppose that also is a malignant polyp, then what? That was my question. That's what.
Yeah, I think if at all, there is now because they have actually removed the polyp fully, you can observe that with the regular surveillance sigmoidoscopies, And if, for example, there is any suspicion of recurrence, then you will have to go back and do a a pan-proctocolectomy or a restorative proctocolectomy. You will have to do remove it up to the anorectum and then create a pouch and anastomose the
Even
pouch.
rectum also should be removed.
Yeah, because if the tumor is recurred there, then you can't then hope that it will not come in the rectum.
This thing was if since sir has already done almost subtotal, it would have been ideal to remove the entire sigmoid colon probably, because if that decision was based on HNPCC and it being malignant, ileorectal anastomosis would have been, I think, probably ideal to avoid this if the margin comes positive and all those things.
Yeah, possibly, yes.
Maybe.
Okay, so what is?
So one more doubt. I have. So generally in obstruction, we would consider the distal bowel to be collapsed, right, sir?
Yeah.
With a lesion, obstructing lesion in the transverse colon, you would expect the descending colon, sigmoid, and rectum to be collapsed.
Yeah.
But per rectal examination, you've mentioned is that it is as roomy. Is that possible, sir?
Maybe it. No. She's asking per rectal examination. We know that's mentioned as roomy. So usually it should be collapsed if there is a proximal obstruction. So is it a correct finding, or how do you justify that? She's asking.
Is it possible that can we have a roomy finding?
Yeah. See, the thing is, for example, many times when you have a lesion in the sigmoid or rectosigmoid, the distal rectum will be ballooned out. That is a common finding. So I don't think there is anything unusual about it.
But this is in transverse colon, with proximal dilatation and transverse colon.
Yeah. Proximal dilatation, agreed. And see, I think that.
Anya, usually that finding is seen in small bowel obstructions, where you can see proximal gross dilatation and distally beyond the obstruction, the loop will be collapsed. In colon, it is not a dictum that it has to be always collapsed.
Actually, one of the things when you, Sania, one of the things when you do a rectal examination, apart from the usual things like blood and things like that, if there is a dilated, sort of roomy rectum, you should suspect that there is a lesion just above that. If it is not, at the tip of your finger, then you should suspect that there is possibly a lesion just beyond that.
Just beyond that, sir. But what about transverse colon? This was in the transverse.
Even with transverse colon, as I think Niranjan said, the rule that the distal loops are collapsed doesn't usually apply to the colon.
Okay, sir. Okay, sir. Thank you.
Okay. I think the time is already 1 hour, 10:20. So we could have discussed for future management, depending on the histology and all that. We don't have the histology now. So we'll probably have a class where we can discuss all those things. I think
maybe Swarup can just put in few points if it is adenocarcinoma.
Swarup, with
what if it is adenocarcinoma of the primary and polyp being benign? The other option is polyp also being malignant and this also is malignant, adenocarcinoma. Is there any difference with respect to management?
No, you should ask the PG what is the further management. You're asking Swarup.
He wanted to finish the class, sir. Was closing Allah, so final comments.
No, don't rush through. Don't rush through the class to take a second class. What is that?
Okay. Swarup has already left, I think, anyways.
So we'll wait for the histology and then we'll probably have a discussion about
let them read and come
further
meanwhile.
management.
Yeah, let them read and come.
So read up about malignant, colonic malignancy, the management and everything. And I think we have discussed all the options. I thank Professor Ballal, Srikant, Niranjan, Subhash, and also Swarup for attending. I think it's a very fruitful discussion. Lot of difficult points have been brought out. And Vinod, your presentation needs to be a bit more slicker. Otherwise, you presented well. So, and all of you take this opportunity to read about the colonic malignancies in detail. Okay, right.
Thank you, sir.
If there is no other
Thank you, sir.
question,
Good night.
we'll
Night.
close. Good night, everybody.
Thank you very much, sir. Good night.
Sir, thank you very much for attending, sir. Thank you.
Thanks. Thank you, sir.